Hi, everyone. Kim Hollander here. I'm the Executive Director of the Oxalosis and Hyperoxaluria Foundation. Welcome to the OHF On the Road Summer Webinar Series. This is session 2, where we talk about your voice and the vital role it plays in making a difference. Today, we're going to learn, engage, and connect with families, patients, caregivers, and industry partners. We're uniting to build and activate the hyperoxaluria community at a personal level. This is part 2 of 3 of our summer webinar series. Today's focus is how you can elevate your voice by participating in quality of life surveys. You're in the driver's seat. Quality of life surveys have the power to educate regulatory agencies like the FDA, the EMA, NICE, and others so that they can understand what it is really like living with hyperoxaluria. For over 2 decades, the US Food and Drug Administration, FDA, has encouraged the incorporation of patient perspectives into drug development. A major component of the patient perspective is a drug effect on quality of life. It's the power of the patient voice. Proof? Study surveys like a quality of life were used to help get our first drug to market for PH1 in October and November of last year. Now is the time to participate and share your voice in these simple studies. There's absolutely no risk, but the power and impact that you'll have is tremendous. A big thank you to all of our sponsors, especially our partners, Alnylam Pharmaceuticals and Dicerna Pharmaceuticals, for allowing this webinar series to happen. Today, we have incredible guest speakers. First, we have Dr. David Sass from the Mayo Clinic and representing the Rare Kidney Stone Consortium, and Frank Mortariski from New York, NYU School of Health. Some things to go over. Today's webinar is scheduled to last about under an hour. You'll be muted, but you have all the speakers to present without interruption, but you can ask questions whenever you choose. The webinar will be live and you can view it at any time on OHF's Facebook or YouTube channels. To ask questions during the webinar, please use your Q&A and chat button at the bottom of your screen. We will do our best to answer all our questions at the end of the webinar, but you can ask them at any given time. And without further ado, I'll introduce Dr. David Sass, the Assistant Professor of Pediatrics from Mayo Clinic in Rochester, Minnesota. Thank you, Dave.
Hello, everyone. Thanks for tuning in. As Kim mentioned, I am a pediatric nephrologist at the Mayo Clinic in Rochester, Minnesota. I specialize in pediatric kidney stone disease and especially genetic kidney stone diseases like primary hyperoxaluria. So Kim is running the slides here, so I'm just going to prompt her to advance each of the slides. And again, I'll be happy to answer your questions after I finish talking and after Frank finishes talking. So to start, what is quality of life? So one definition is the degree to which an individual is healthy, comfortable, and able to participate in or enjoy life events. It's considered a valid indicator of unmet needs and intervention outcomes. It's self-assessed health-related quality of life is a more powerful predictor of mortality and morbidity, meaning death and illness, than many objective measures of health, which it makes it a very powerful tool. Go ahead to the next slide, please. So do we always express how we feel? So this figure is to illustrate the difference between how we might respond typically to questions about how we feel, which your doctor or your family's your friend might ask you how you're feeling, and you might say, I'm feeling fine, when in your brain, in the background, you're thinking, I am not doing okay. Drinking all this water is a lot. It's a big strain. I have another appointment tomorrow, but I missed work twice already this week. because I think I'm getting another stone. So it's just to, the quality of life studies are to help to express what's truly going on in your mind when you might have trouble expressing it in your normal day-to-day life. Next. So the quality of life studies are to help you express how you feel, and your voice is important, as Kim already mentioned. So quality of life research is designed specifically to get the voice of the patient and the caregivers of those patients. It measures how well or how poorly you're feeling. It reports on what you say and quantifies or puts into numbers how you feel so that people will know the magnitude of the impact of primary hyperoxaluria on your life. So then, once we gather this data, these results can be published in scientific journals so that there's awareness of this impact and that your voices are heard. So publications are really important for pushing the science forward and convincing people that need to be convinced that we need to push the science forward. Next, please. All right, so this all sounds sort of very soft and touchy-feely. Can it be studied scientifically? Well, yes. So there are a lot of surveys that have been developed that ask a broad set of questions about how you perceive your health status and activity limitation. Because quality of life is a measurement that's been discussed for decades, going back to the 1950s, there are now literally hundreds of survey instruments that are validated. We sometimes call these patient-reported outcomes, or PROs, that exist. I did a literature search and saw that there are something in the neighborhood of 360,000 quality of life research studies that have been published. So some of these are general health, designed to ask general health questions, and some are designed to ask specifically about your disease state. So you know, doctors and scientists have to choose which is the best tool or PRO to measure the quality of life in a specific condition. So, you know, we asked, well, what's the right tool for PH patients? How do we pick tools that are specific for PH patients? Next, please. So here are just some two examples of questions that might show up on a quality of life study. So the first one here, the general health question. This question comes from a tool called the SF-36, which is a more broad, general, not disease-specific health quality of life tool. And so it asks, in general, would you say your health is excellent, down to poor? And you choose the number based on your feeling and move on to the next question. The next one, the panel on the right, is more specific to kidney stone issues. So this one comes from the Wisconsin Living with Kidney Stones questionnaire, and it asks about how stones affect your energy, your sleep, pain, frustration, and a bunch of other questions. So that's an example of a more specifically designed quality of life study. And so for our purposes, we've combined some of these to provide what we think is the best way to evaluate patients with PH and their caregivers. Next, please. All right, so here are an example of quality of life survey for PH patients and caregivers reporting on how PH impacts work or school. So the first example here is with employed adults. So when you see in a scientific study, it says N equals some number. N is the sample size or the number of patients. So in this case, it's the number of people who responded to the survey in this way. So N equals 4 humans. If you're reading a study about animals that used mice, N equals 12 would be the 12 mice that were involved. If you're looking at a study on the COVID vaccines, N equals 75,000. 75,000 is the number of people that were involved in the initial COVID vaccine studies. So here we have employed adults, N equals 4, who responded that their PH was a reason for not being able to function at work all the time. That's a big deal. That's something we need to know about, and something that might not be part of your usual doctor's appointment, right? Your doctor probably doesn't ask that question. Next example, employed caregivers, N equals 9, responded that caring and concern for their child with PH was a reason for not being able to function at work or missing work completely. And then the final question is related to children, right? So N equals 11 children who answered this question, who attended the school, had a median of 15 hours of missed class days in a typical month due to their pH. So all very impactful real life examples. Next, please. Here's an example of a figure from a quality of life publication. So this was a survey of pH patients and caregivers that was recently published in a major nephrology journal called the Clinical Journal of the American Society of Nephrology, or CJASN as we call it. Patients and caregivers were asked what is a concern to them. In other words, what affects their quality of life. And we won't, there's a lot going on in this figure, so we won't go into tremendous detail, but just know that on the y-axis, you have all these different potential fears and concerns. The orange answers represent the patient's responses. The blue ones tell you about the parents or caregiver responses. So just in this first example, it shows that patients, 71% of them are fearful of transplant, while 52% of parents or caregivers are fearful of it. And you can see down the line that it's interesting, right? There are discrepancies between what parents worry about and what patients worry about. And knowing these differences is important. Next, please. All right, so after we do the surveys and we gather this data on quality of life, what happens then? Well, then we take these results and we analyze them statistically, using statistical expertise. And initially, often we present them at scientific meetings so that they can be seen by other doctors and other stakeholders like insurance payers, policymakers, right? And it also, we get a lot of feedback from other doctors and scientists who say, okay, well, that's interesting. Well, what about this question and that question? And then we can use that information to help craft the paper that we want to publish in a major journal. So that's usually the next step. So they can be published in a journal like Dr. Lawrence and Dr. Wattenberg did on that CJASN paper we referenced. And then next, we can also do press releases. So these are, this is when we sort of condense all the information into a palatable, understandable package for the media to then present out. Sometimes it gets picked up by newspapers or magazines or other news outlets. Next. So some of the practical uses for these quality of life surveys, they measure the impact of a particular disease beyond medical outcomes. Again, beyond what you might learn from a doctor's appointment. It takes it that step further and looks at the real life impact of disease. And it helps us establish the current needs of patients and families, justify the need for further research, and justify innovation for treatment and management. As Kim acknowledged in the beginning, it was really quality of life and parent and caregiver interaction that led to the development of the FDA-approved drug lumasiran. Without quality of life, we would not have been able to convince the FDA that our clinical trial design was valid. So it was crucial for that step. Next. All right, that's where my part ends, and Frank Motorsitsky is going to take over. I look forward to your questions at the end. Thanks for your attention.
Dr. Sass, thank you so much for that incredible overview. And I want to encourage people, it's okay to ask questions in the chat and Q&A at the bottom of your screen. You can start to ask questions now, and then we'll circle back to Dr. Sass at the conclusion of the webinar. And so start firing away on questions. Next is Frank Motorsitsky from New York University School of Medicine. And Frank's going to give you a nice overview on a little more of the technical things, but you're going to find it fascinating. So here we go. Frank?
Thank you, Kim, and thank you, David. My name is Frank Motorsitsky from NYU School of Medicine. I'm the PI for health-related quality of life in our Rare Kidney Stone Consortium. And I will go a little bit about the concept that already Dr. Sass mentioned, and focus a little bit on the SF36, and will show some results that we actually found in our Rare Kidney Stone Consortium. Next slide, please. Next slide. So when we talk about diseases, disabilities and handicaps, these are all internationally classified and defined in the ICD-10 or ICF-2. So for example, PH is classified as E72.53. So this is worldwide pretty much the same. For health-related quality of life, we don't have a clear international definition. Sometimes we are using quality of life and health-related quality of life to describe the same concept. We should use health-related quality of life to differentiate between these two terms. The concept of health-related quality of life has evolved over time to include the aspect of overall quality of life that clearly affects physical and mental health. Next slide, please. We could measure health-related quality of life with different instruments, or what we call questionnaires, from simple to complex. These questionnaires can be categorized as index instrument, profile instruments, non-disease specific or disease specific. I will talk about a non-disease specific profile instrument in a little bit. Next slide, please. This is pretty much an illustration of a very simple index instrument, and we all have seen this most likely in a doctor's office, or our doctor asked us about pain, how much pain we have on a scale between 0 to 10. And this is again expressed in one simple number. Next slide, please. The SF-36 is a non-disease specific profile measurement. This includes 8 domain scores. We see the 8 domain scores on the x-axis and 2 summary scores that are not shown here. The SF-36 is norm-based to the US standard population. That means the US standard population is defined as a score of 50. So that means if somebody scores above 50 or higher, it has a better quality of life or better than the US standard population, and the same with the lower score. So this is a lower quality of life in that particular domain. In this example for asthma, we can see that physical functioning, role functioning, and general health, for example, score very low, around 40. These results with the star attached are significant compared to the US standard population. The SF-36 is pretty much the gold standard in the...
Frank, you're muted.
Sorry about that. SF-36 is, now I lost it, used worldwide in all kinds of diseases, and we can compare, for example, rare kidney stones with other diseases of interest. Next slide, please. So the SF-36 includes 36 questions. It takes maybe less than 10 minutes to fill this questionnaire. This SF-36, or these questions, are calculated into 8 domain scores, and these domain scores are translated into also summary scores. Next slide. So in our new study that we are planning to do together with the OHF, we are planning to use the SF-36 and the Wisconsin QOL, so as profile measures, and we wanted to include also family impact questionnaire and a work-related questionnaire to have a better picture of the burden of participants in primary hyperoxaluria. This slide illustrates the main features of the SF-36 and the Wisconsin QOL. Next slide, please. I want to show now some results from the rare kidney stone consortium study that we did. So when we looked at the first analysis of our data, we realized that the PH group overall was usually around a mean score of 50. When we calculated for different subgroups of PH patients, it looks quite different. Here, for example, we see PH1 and PH2 participants over 4 years, and these participants had a kidney or a kidney and liver transplant. And we can see here that actually these participants are doing quite well over time, except of the domain general health. We are not sure yet why the domain general health is always below the mean of 50 for the US standard population. And we have to check our data bank if we maybe find additional information to explain this. But overall, patients with a transplant experience a better quality of life based on our study data. Next slide, please. This is a different view for PH patients without a kidney or liver transplant, divided by 4 different groups: type 1, type 2, type 3, and an undefined group. So we can also see here that the profiles for these 4 groups are quite different. Type 1 and type 2 experience overall a better quality of life, while type 3 and the undefined group have some domains that are below 50. The undefined PH group had actually the most amount of stone events within a year of taking the survey, and that will most likely explain why their quality of life is not that good. And I will show that on the next slide, please. So this is a different view where we look at all PH patients without a transplant, and the question was here, how is their quality of life? When we check for the last stone event, we created there 3 stone event groups. And the first one is a stone event within 30 days of taking a survey. The second one within 31 to a year. And then the last one is the stone event is more than a year from taking the survey. And we can see here that people that experience, of course, a survey, event within 30 days of the survey, we can see that also in a quality of life. So we always have to control for the last stone event when we are using the SF36 and probably also the Wisconsin QOL to make the results much more meaningful and to interpret all these data in the correct way. Patients with no stone event in more than a year experience actually the best quality of life in our sample. And this is one reason why we want to combine the SF36 with other questionnaires to have a full picture for the burden of PH patients and explain the quality of life better. Thank you.
Thanks so much, Frank. Such fascinating news and just the studies that come out of it, the incredible way it can help not only regulatory agencies better understand what it's like to live with PH or EH, but also that these studies are then used by drug developers to also do a better clinical trial and organize things to help patients. So I just want to thank both of you for the great presentation. So we're flooding, which is good. Start sending those questions via your chat at the bottom of your screen or the Q&A, and let's see what we have. Okay, so someone is asking a quality of life questionnaire. Let's see. I'm reading. Okay, what is the best way for me to find studies in quality life for patients and caregivers with primary hyperoxaluria? Maybe I can sort of chime in for this one.
I was
So
going to say, ask Kim. That's
yeah,
the answer
ask
to that
Kim.
question.
Yeah, so I think you're coming to the right place. So if you're watching this, this is a great way to start to understand about quality of life. We are working closely right now to launch several quality of life surveys here in the US and then also in various countries around the world. So these pop up all the time. And what we would encourage you to do is really reach out to Julie, or just put your name in the chat button right now and put your name and some contact information to Julie Bertarelli. And then we'll have you on a list. So as soon as these research studies start to happen, we can inform you and keep you in the know. So that's an easy way to do it. Next question, what is the best way to make sure that my voice is heard? And I think maybe I can also answer this one. The best way is participate. Join webinars, take the studies, participate what we did, the patient-focused drug development meeting back in October of 2020. This was an opportunity for patients around the world to get in front of the FDA and voice your opinion on what it's like to live with primary hyperoxaluria. It all starts with you.
And Kim, I'd like to add also that individual participation really compounds the impact of a survey. So in other words, by participating, yes, your individual voice is heard and your opinions are documented, but it also makes the results of the survey, the overall results, more powerful, right? So the more people who participate, the bigger the N, right? The sample size that I talked about earlier, the more people pay attention to it, right? So a survey where 10 people participate is fine, that's good. But if you get 20 people to participate, people are going to listen twice as hard. And if you get 40 or 50, well, then people say, wow, this is really an important survey, and they really pay attention. So it's sort of, double the impact if you participate.
Yeah, and I think by joining together and showing that the primary hyperoxaluria and enteric hyperoxaluria communities are one, makes us stronger. And people will listen to more voices. So that's why it's really important for all of us to participate. Okay, and another question. Thank you very much for your great efforts. Actually, I would like to express my fears and worries about my own quality of life. I'm a 30-year-old patient who is in renal failure with no possible treatment in my country. I think the medication should be available in more markets around the world. I'm here to talk about surviving, not just the quality of life. And so, Dr. Sass, maybe you could just sort of provide some overview and guidance.
Yeah, so it's a very challenging situation, right? So we're talking about healthcare resources, basically. And unfortunately, right, it's not everyone has the same access to care. It's a problem internationally. It's a problem in the US for sure. So I think, one of the ways we can improve access is by, again, really educating and getting it out there, the impact of this condition. And so, by showing, have a treatment, if we have a new treatment and it's been shown to be safe and effective, we want to get it out to as many people as possible, right? And so one way to do that is by doing these quality of life studies and saying, okay, it's one thing if you can show, that the original data might show, oh, that we lower urinary oxalate by X percentage. Okay, great. The drug is effective, and that, there were very few adverse events. Okay, great. The drug is safe. Okay, well, that's good. Well, but what if we show, so insurance companies or the countries where these decisions are made by government, they might say, okay, that's great, but that drug is too expensive. We're not going to pay for it. Well, if you do a quality of life study that shows that people in your community are missing work, that takes money out of the economy. If you show that their kids are not able to go to school, well, guess what? Okay, that affects their education, but it also means somebody needs to not go to work and be home to care for that child. then they might say, okay, well, yes, it's expensive, but the cost of this disease is even more expensive. So it's a way to sort of broaden the perspective of the decision makers who decide who gets treatment and who doesn't.
Thank you. That's incredibly helpful. And one of the things I think that's helpful, this is a sort of a piggyback question, I think, to the one you just answered. Most surveys are for patients and caregivers in the USA. How do people in underserved countries participate to have their voices heard? And maybe I can sort of chime in. So one of the biggest ways is become an ambassador of your disease. Become an ambassador for the OHF. Start Facebook pages within your countries. We have some Facebook pages that are set up for individual countries within the OHF. There's also other groups, Oxal Europe and PH Europe, that are now starting to get involved and start to make a difference. OHF is working actively with physicians around the world to create quality of life in different countries. And so it really is, it takes a village. We can't do it all. We're a tiny organization, but we can do it with the help of all of you on today's webinar. And the more that you start to participate and get your voice out there and talk to your own physicians and also medical institutions and say, we think this is really important. Can you reach out to OHF? We might be able to get a quality of life within your country. So it really is a full circle moment. And it does take a village. So keep doing what you're doing, stand up, and let's make impact for all of us. This question might be good for Frank. What explains the overall lower general health score for PH3 patients? Is there any correlation between PH3 or any of the PH types and other seemingly non-related health conditions?
This is a very good question, Dan. Thanks very much. So we need to, I don't have a clear answer right now. What I would think off the top of my head is that this is probably related to some other underlying comorbidities. So, and we have to check our data bank and to make sure that we capture the data correctly and correlate it. But what we have seen in other rare disease or rare kidney stone diseases, that usually is explainable by other comorbidities like diabetes and mental health, like depression or anxiety. They usually explain these domain general health or a lower score in this domain.
Great, thank you. Some other questions that have rolled in. How long does it take in general to fill out these forms? Frank, we'll turn that to you.
So as I mentioned earlier, the SF30 takes usually between 5 to 10 minutes. The WIS call also includes 36 questions, so it's pretty much the same time. And the other two are questionnaires. I think in our planning, we also estimated around 20 to 30 minutes, so that you that somebody can complete the full set of questionnaires that we are using in less than an hour, or 45 minutes to 60 minutes, I would say.
Yeah, it's a short amount of time though. These are quick and easy forms to sort of wrap your head around, and you live this every day. So once you see the questions, they'll start to make sense. Thanks, Frank. This is an interesting question. What happens to my answers? Also, who will see my answers? And maybe I could just take a stab at this. Your individual information is combined with all the responses from the other people and reported as a whole. So nothing individually is presented externally. They're all anonymous. And usually those combined results are published. And I think one of the biggest things that we can see from the patient community, we're publishing the Voice of the Patient report from the patient-focused drug development meeting that was held in October last year. And then also there was a wonderful paper about patient perspectives that was published also in CJASN, which is a very prestigious medical journal. And that was all about patients and living with hyperoxaluria. And that got published because people cared and stepped up and participated. So this is a really good opportunity to remain anonymous, but make a giant impact into your disease. Okay, Dr. Sass, why do you do these studies?
Well, so working in rare diseases is a special kind of challenge, right? Because something that's super common like diabetes or hypertension, there are hundreds of researchers because there are millions of patients with, they're super high impact, right? If you can make a small change in diabetes care, you can help millions of people and save billions of dollars. In rare disease, it's a little more challenging because there are fewer stakeholders, right? But to those stakeholders, it's super important, right? And so they're sort of people with rare diseases can feel like they don't have a voice. And I feel like it's, part of our obligation as doctors to help amplify that voice and give them some power so that we can improve things. So honestly, I got into PH because when I first was starting out, I ended up having 2 kids with PH when I finished my training, and just became, really interested in it and in their care. And that kind of launched me into the research area and joining forces with the Rare Kidney Stone Consortium. And it's kind of what brought me to the Mayo Clinic. And so, working with the OHF, it's very rewarding. And quite honestly, there's a need. Someone's got to do it, right? And so I feel, I'm very interested in it from an intellectual standpoint, but I'm also emotionally attached to it because of my patients. So that's why I do it. I think it's been very rewarding, right? So the advances that we've made since I started out in this field are tremendous, and a lot of patients are going to be better off for it.
Thank you. That was wonderful. Frank, will my physician or my insurance companies see any of the information?
Oh, so we are not sharing this with anybody out there. We have a chance to run personalized reports in our Rare Kidney Stone Consortium, for example. We could generate a little report and give it to the patients if they are interested in their own results, to show that to their family members or even to their physician. But in general, we are not sharing or disclosing any of these results with anybody that is not mentioned in the consent form.
Great. When does new research start? And maybe I can chime in. So OHF is conducting, hopefully, a research study soon that will be looked at by an institutional review board. And we hope to see that approved and then immediately start that study. So we highly recommend that'll be a US study to start. But we are working with physicians in other countries also to begin other quality of life studies. And sometimes these quality of life studies, sorry about the cat that entered, these quality of life studies are really pushed and driven by you as the patient community and caregivers. You can make an impact by talking to your physician and saying, if it's not in your country or a drug is not approved, demand and say, we want to work together with you, and please conduct quality of life to help drugs get to market in our country. You have that power. And it's just a matter of standing up, believing, and becoming an ambassador for your loved one or yourself. Okay, and we're wrapping up some of the questions. There's a few that just came in. What happens if there's something on the form I do not want to answer? And we'll give this to Frank.
usually these forms are designed that everybody could answer all questions, and that would be also important to calculate the results. If something is missed here or there, we have a technique to impute this result in a different way. So, when it's not more than 50%, usually, and in most questionnaires, if a question is missing, one in out of the 36 questions, that will not invalidate as of 36. So if we have a questionnaire where more than 50% of the questions are not answered, then we cannot apply this technique anymore, and this questionnaire becomes then invalidated.
So can I chime in also? So I would say that from those of us who are, using this information and analyzing it, we always encourage people to just do the best they can. Sometimes, we've all taken surveys where you're like, well, I don't know that this question is really relevant to me, but it's more useful. The data are more solid and more valid if you just take your best shot at answering the question and move on to the next. By the way, the other thing I want to say, Kim, I don't know if you saw it. So outside of the chat, there's another question in the question answer section that I want to answer. So someone asked, is quality of life affected by age or age of diagnosis? So there are different tools that are designed for different age ranges, and we tried to take that into account when we design our studies. Is this for children or is this for adults? So the answer is yes for age of the person answering the survey, but not necessarily age of diagnosis.
Great. Thank you, Dr. Sass. Do you pay people to participate in these studies? Would you like me to answer?
Yes, Kim.
Okay. Some studies do offer payment, but not all of them do. So once you sign up for a study, or even before you sign up for this study, you'll see whether or not that is a paid study. Payment is made available through sometimes a sponsor for that study. And so sometimes that's nice because patients are compensated for their time. So you just have to look at the details, but they do vary. And let's see. I think we pretty much have gone through all the questions. Hold on, there's
another one in the Q&A.
Yep.
That says, what explains the overall lower general health score in PH3 patients? Is there any correlation between PH3 and any of the other PH types and other seemingly non-related health conditions? So I think that Frank may have a different answer. I think we don't know. I think you're raising a great question because PH3 tends to be the least severe, right? That's the sort of conventional wisdom. So why do they have a lower general health score? And so the great thing about the quality of life survey is that it exposes that exists, something that you might not have assumed exists. And then the next phase is to say, okay, well, why? And try to get at that. I mean, I could speculate. We know that PH3 patients do tend to form a lot of stones and pass a lot of stones, even though their kidney function is generally maintained. So that might be the answer. But that would be the next, sometimes quality of life studies are useful to trigger the next set of questions in a research study.
Yeah, and I think to piggyback off of that point, think about this. We just got our first drug approved as a community for PH1, and there's still treatments that are in the queue, and that's something you'll learn about on our Series 3 webinar that's happening in a few weeks. One of the things that we have to be mindful of as a community is to make sure that we have representation for patients with PH1, 2, 3, and unknown forms, as well as enteric patients. And so really, rallying the troops within the patient communities that sort of haven't had as much attention or has been in the spotlight, like PH1. This is really important as we move to a study that hopefully will get approved relatively quick and that we'll start to implement maybe this summer and even into early fall. So start start getting people, if you know someone living with PH2 or PH3 or unknown forms, have them participate in the study. It's going to be critical as we move things forward. And again, it really does take everyone's voice to make a difference. Well, I think that's it. What I do want to encourage you, if you haven't already, is to please, right now in the chat button, go ahead, click on Julie Bertarelli's name, send her your email and your name. And what that'll allow us to do is say, I want to participate. This is the country I live in. And Julie will keep you informed every step of the way. You can also always check OHF Facebook, our Instagram account, Twitter, because we'll be announcing anytime a study is made available. And that's US and around the world. So keep an eye out. Make sure that you all are being a part of the community. And please, your voice is vital to getting drugs to market, to making an impact. So drug developers say, I want to start to discover and make a new drug to help patients living with PH. This is it, guys. You're in the driver's seat. Let's get it done. I can't thank our panelists, Dr. David Sass and Frank Motorziski, for an excellent overview today. We couldn't have done this without you, so thank you. Also, on August 17th, chime in again for approved treatments and drugs. This, we're going to walk you through what's coming down the pipe. What does this look like? Do we have more drugs in development? The answer is yes, we do. But we have to make sure that each drug gets to the finish line in every country so that every patient around the world has access to drugs. Again, thank you to Alnylam and Dicerna, our senior sponsors, and we thank you for joining in today. Please share this webinar with as many people as you can. Share it with your family and friends so that they understand, because sometimes we're looking for caregivers and families and friends to also chime in on quality of life. And have a great day. Enjoy your summer. We'll see you at the next one. Bye, guys.
Bye. Have a great day.
Bye.